You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 24th, 2026. This week, PCSK9 inhibitors in patients with high-risk diabetes without atherosclerotic disease, the CAAN-AF trial, conduction system pacing versus BiV pacing, PFA and stroke, and how therapeutic fashion can infect expert consensus statements. Now, we've had two major heart rhythm meetings, the ERA meeting and HRS, so forgive me for covering many rhythm-related topics this week. But let me start with an important sub-study of the VESALIUS-CV outcomes trial of evolocumab, the PCSK9 inhibitor, versus placebo in patients without prior MI but at high cardiovascular risk. Now, in the main VESALIUS cardiovascular trial, published in New England, more than 12,000 patients with atherosclerosis or diabetes, but without a previous MI or stroke, who had LDL cholesterols greater than or equal to 90 milligrams per deciliter, were randomized to evolocumab versus placebo. Specifically, there were four groups of patients enrolled in this trial: those with CAD, those with cerebral vascular disease, or PAD, or high-risk diabetes. The main trial found a statistically significant 25% reduction in a 3-point MACE of coronary heart disease death, MI, or stroke. The absolute risk reduction was small at 1.8% or an NNT of 55. The endpoint was driven by MI, and there were no differences in coronary heart disease-related death. Now, the question of this new substudy, published in JAMA, was to investigate the group of patients who had high-risk diabetes but without atherosclerosis. Specifically, again, the 3,600 diabetic patients in this subgroup study had had no prior revascularization, had no stenosis greater than 50%, and had a CAC score less than 100. Now, before I tell you anything, recall that while 3,600 patients seems like a lot, it is slightly less than a third of the main trial. So this is a small slice of the main trial. So about 1,800 patients were randomized to evolocumab and about 1,800 to placebo. And the results: over 5 years, the event rates for the 3-point MACE were 5.0% and 7.1% in the evolocumab versus placebo group. That's a hazard ratio of 0.69 and confidence interval 0.52 to 0.91, which is statistically significant. The absolute risk reduction was 2.1% and NNT of 47. The 4-point MACE, including revascularization, was also 2.9% lower in the evolocumab arm. Now, the same story was seen in the components of the primary endpoint as in the main trial. Coronary death was 1.5 versus 2.0, and this difference was not statistically significant. The benefit in the 3-point MACE was driven mostly by MI, though I have to say that all three components went in the same direction. So my comments on this substudy: the benefit of this drug is modest, and it is statistically robust. The question, I think, is not in any questioning of the trial procedures or the results. These are solid results. But the question comes in the clinical judgment in how to apply this data at the patient level. Now, if you have a patient who has high-risk diabetes or established atherosclerotic vascular disease without prior MI, adding a PCSK9 inhibitor will reduce the composite MACE by a little, but has no effect on death from coronary heart disease. And I'm not saying MI reduction is nothing. It's not nothing. But my question is, at what cost? And I'm not talking just in money to pay for the drug, but what about the cost of the time and effort of taking another medication? That's a tougher question because these patients take a lot of medicines. Now, for patients who are maximizers, who want to do everything to reduce their risk of heart disease, a PCSK9 might be fine. But for others, the difference between 1.5% and 2.0% coronary death, it may be not worth taking the more costly drug. Now, the coming soon release of the oral PCSK9 inhibitor, this may change the calculus a bit because certainly an oral drug is easier to take than the injection. I'll close this discussion with a question, and that is, only 68% of the patients in this trial were on a high-intensity statin. So, when you're faced with a VESALIUS-like patient who's not on high-intensity statin, why couldn't we just increase the statin or add ezetimibe to achieve the LDL goals? I'm asking, I don't know. Let me know what you think. That might be an easier way to achieve the same 3-point composite MACE reduction. All right, next topic, let's get into some heart rhythm business. This is how best to maximize cardiac resynchronization therapy benefit in patients who have permanent AFib. So here's the scenario. Your patient has a left bundle branch block and left ventricular dysfunction and has a CRT device, or you're planning a CRT device. It could be either CRTP or CRTD. It doesn't really matter. Bi-V pacing, or now left bundle branch area pacing, only works when it paces. So if the device is set at 70, but the patient's heart rate due to atrial fibrillation is consistently 80 or greater, then the device gives no benefit. So a CRT only works to help resynchronization when it paces. If the heart rate is always above the lower pacing limit, then you don't pace and you don't get the benefit. You ideally want Bi-V pacing to approach 100%. Now, one way to do that is to give meds to keep the heart rate below the lower rate of the device. The other way to do that is to ablate the AV node. Now, there are a few RCTs and some observational studies that suggest that AV node ablation may associate with better outcomes when you're using a CRT. Yet, AV node ablation is not nothing because it is permanent, and now the patient is dependent on a pacing device. The group in Adelaide, led by Dr. Prash Sanders, decided to study this important and relevant clinical question. European Heart Journal has published the CAAN-AF trial of AV node ablation versus medical rate control in patients with AF who have CRT-D devices. These are 436 patients were screened and 143 patients were randomized from 28 centers in 4 countries. Inclusion criteria required permanent AFib and a typical CRT enrollment criteria, so left bundle branch block, LV dysfunction, etc. The primary endpoint of CAAN-AF was all-cause mortality and non-fatal heart failure events. There were also numerous secondary endpoints like quality of life, 6-minute walk, unplanned hospitalizations. Now, CAAN-AF is an old trial. It began in 2013 and went through 2020. But at the first interim analysis, there were identical primary outcome events in each group, and a futility analysis suggested low conditional power, and the Data Safety Monitoring Board recommended stopping the trial for futility. In the final analysis, there were only 76 patients in the medical rate control group versus 67 in the AV node ablation arm. The mean age was 71, 90% male. The mean QRS was 160 milliseconds, and almost all patients had a typical left bundle branch block pattern. The LVEF 29%, but perhaps most crucially, the resting heart rate at baseline in both arms was only 72 beats per minute. The Bi-V pacing percentage at baseline was 75% in the medical rate control arm versus 89% in the AV node ablation arm. The incidence of a primary outcome, the main results, here it is, 32.8 per 100 patient years in the medical rate control arm versus 36.8 per 100 patient years in the AV node ablation arm. The rate ratio was 1.16 with very wide confidence intervals that go from a 0.60 all the way up to 2.24, and obviously the p-value is going to be high at 0.6. All of the components of the primary endpoint, death and heart failure events, were similar. The Bi-V percentage was pacing percentage was higher in the AV node arm, 98% versus 87%, though I have to say 87% in the medical rate control arm is quite good for just tablets. The authors concluded that, that this trial of patients with permanent AF and CRTD found no evidence of a reduction in all-cause mortality in non-fatal heart failure events with AV node ablation compared with medical rate control. The authors go on to write that the trial refuted observational studies that previously found that AV node ablation associates with large reductions in mortality. They offer reasons why this might be. For instance, the trial enrolled patients with a decent resting heart rates and also had at baseline pretty high BiV pacing percentages, as well as medical therapy of heart failure is quite good. What's more, the event rates were lower than expected, probably because the heart failure was less severe than in the old trial like Companion. These patients in CAAN-AF had mostly class 2 rather than class 3 heart failure. So, my comments. This trial confuses me a little bit. I mean, if I had a patient with permanent AFib and a CRT device, and their heart rate was 72 at rest, and the device was BiV pacing pretty well, say over 70 to 80%, I would not consider AV node ablation. I might add a little medicine, but I wouldn't do AV node ablation. You could either increase the pacing rate to say 75 or 80, you touch up a little of the drugs, maybe add digoxin. I mean, we even have the DIGIT-HF trial, which showed that DIG in HFrEF patients is a pretty darn good drug for reducing the endpoint of CV death and heart failure hospitalization. So I'm not surprised that AV node ablation did not show improvements in these fairly well compensated and well rate controlled patients. Now, I guess maybe in other countries people were doing AV node ablation in all CRT patients, and this data may slow that. But I would strongly warn against using this data to withhold AV node ablation from patients with AF and a persistently high ventricular rate despite medical rate control, because the combination of left bundle branch block and high rates of atrial fibrillation, these are devastating conditions for the patients who have HFrEF. I mean, you have a patient with HFrEF who has a left bundle, and that left bundle rate in AFib is fast. These patients do terrible. And AV node ablation may be very important for these patients. And of course, these patients were not like those enrolled in CAAN-AF. So I wouldn't apply this data to all patients with permanent AFib and CRT devices. We also have to make some comments about statistical interpretation issues with this trial. So the relative risk for the primary came out at 1.16, so a 16% increase in events in the AV node ablation arm. But the confidence intervals go from 0.60, which is a 40% reduction in events, up to 2.2 times worse. So the authors say, or they write, that they found no evidence of benefit, but I can hear Vanderbilt statistician Dr. Frank Harrell sternly saying the absence of evidence is not evidence of absence, meaning that while the top-line results say no significant difference, the wide confidence intervals do not prove there was not a benefit or harm. I strongly suspect that Professor Harrell would say this is an uninformative trial. The data do not answer the question because the 95% confidence intervals include a 40% benefit or 2.2x harm, and this precludes using this data at the bedside. Now, I realize that all DSMBs have tough jobs, and I don't know the first thing about a futility analysis, but I have to say I'm sad that this trial was terminated early because now we have wide confidence intervals and we just don't know. We have uncertainty. Okay, next topic, stroke rates in PFA versus thermal ablation. Now, a long time ago, I wrote an editorial for Jack on one of the early ITE trials for PFA and persistent AFib. My co-author, David Tomlinson, and I worried that there had not been adequate study of CNS safety. The concern is that PFA creates substantial microbubbles in the left atrium. So now we have a single-center report from Beth Israel in Boston. It's presented at last week's ERA Congress, and it provides worrisome data on stroke rates. This is only an abstract form, which I rarely cover until the paper is published, but I make an exception here because The momentum behind PFA is like nothing I have ever seen in my career. So unlike left atrial appendage closure, at least PFA has multiple trials that show equivalency in efficacy and an increase in procedure speed. The problem with these trials is that events such as stroke have incidence rates below 1%. These are hard to sort out with small trials. And I think for safety signals such as this, you need large observational databases. And this is what the Beth Israel team has provided. They looked at a prospective registry from a high-volume center between 2022 and 2025 to compare 1,500 PFA procedures and 2,000 RF ablation procedures. While not randomized, the baseline characteristics of these two groups were comparable. Now here's some of their findings. Compared to RF procedures, patients received PFA earlier in their disease course, as evidenced by the lower use of antiarrhythmic medications and cardioversions. PFA procedures had shorter left atrial dwell times. PVI only was performed in 19% of PFA versus 46% of RFA cases, while PVI and posterior wall isolation 57% PFA and 25% RFA. Overall, here's the main result. 7 patients had stroke, that's 0.47% after PFA, and 2, 0.1% after RFA. The unadjusted risk difference was 0.37% with confidence intervals that were below 1. So in this higher rate of stroke in PFA also held up after doing statistical adjustments. Now, another reason I cover this abstract is that it might be a while before it is published because negative data for new products, especially one as hot as PFA, might have difficulty getting published. This paper won't likely be into New England Journal of Medicine or Lancet either, because these journals tend to favor RCTs finding positive findings of new products. Now, you might push back and say, John, it's only 7 versus 2 strokes. That could be noise. And I would admit that you might be correct, but it might not be noise, and if it's a true signal, a 63% higher rate of stroke in 3 years with the PFA system is quite sobering. Now, I'm about to do something that I almost never do. I'm going to invoke my experience in our hospital. My partner and I do approximately 500 AF ablations a year, and we've been doing this for a decade or more. Before PFA, it was all RF ablation. Now, neither I nor he can recall even one documented stroke, like 0. Now, of course, we may have missed one that followed up somewhere else, but we don't know of one. That there were 7 strokes, 7, all documented with imaging in 3 years, is way more strokes than we should see. Now, the authors include a table with the characteristics of the stroke and the characteristics of the procedure, and most of these strokes occurred with one company's PFA system. Of course, that company was first to market, but other company systems were involved as well. Again, PFA has been an advance, but our profession would be very wise to identify these signals so as to modify procedures to reduce these stroke rates. Now, we could do things like give more heparin during the procedure, and the companies could do things like changing the algorithm of the energy delivery. But I think we need to be very cognizant of these potential safety signals with PFA. Next topic is conduction system pacing. 5 new CSP studies have been presented and published. As many of you know, I was an early adopter of conduction system pacing, or CSP, first with hip bundle pacing in 2016, and now with left bundle area pacing. We do this at our center routinely in nearly all patients who receive a non-leadless pacemaker. It's just our standard. But the role of CS pacing as cardiac resynchronization systems is less well defined. We have small studies, both randomized and observational, that show that when you get proper conduction system pacing, where the conduction system is actually captured, not the RV myocardium or septum, this provides similar hemodynamic benefits as biv pacing. Most implanters, including myself, have seen amazing super responses when a his bundle or left bundle lead narrows a typical left bundle branch block. But what we lack is proper RCT level evidence in all comers. Well, JAMA Cardiology has published 2 conflicting CSP versus biv pacing trials in March, and the ERA meeting featured 3 more similar studies. And I will briefly review each of these because each have caveats and each taken alone preclude making strong conclusions. So briefly, in JAMA Cardiology, the HeartSync left bundle branch RCT randomized only 200 patients with a low LVF and left bundle branch block to biv pacing or left bundle branch pacing, and this was done in China. A primary outcome of death or heart failure was 74% lower in the left bundle area pacing group, 8% versus 28%, hazard ratio 0.26, highly statistically significant, and the driver of the endpoint was a reduction in heart failure. There were no differences in death noted. The echo response rates were similar, but there were more super responders in the left bundle branch pacing arm. So a super positive trial from China. Also, in the same issue of JAMA Cardiology was the Brazilian PhysioSync-HF Trial, which randomized 173 patients with HFrEF, left bundle branch blocked, CS pacing, or biv pacing. Their primary endpoint was death, heart failure hospitalization, urgent heart failure visit, or a change in LVEF. In this trial, CSP failed to meet non-inferiority and was actually inferior to biv pacing. The odds ratio was 2.36, so clearly not non-inferior and inferior. Surprisingly, there were 11 versus 4 deaths in the CSP versus biv pacing groups over the 12-month follow-up. 3 of the 11 deaths were procedure-related, which is shocking because CSP is well established as a safe procedure. I'm not sure I know what happened. The authors explain the inferior results to lesser experienced centers being involved in the trial. This was supported by the fact that 1 in 5 left bundle branch area pacing cases had deep septal pacing rather than true conduction system capture. And to be fair, having done this for 10 years, I will tell you that it's not always easy to get true conduction system capture. So at the European Heart Rhythm meeting, we had the Spanish left bundle CRT trial, and it was published in European Heart Journal, and it also randomized about 176 patients with typical left bundle branch block in 11 centers. Here, the primary endpoint was the proportion of patients with a positive CRT response at 6 months, and this could be defined by either a clinical composite score or a greater than 15% reduction in LV end systolic volume, and this was achieved in 94.6% of the biv arm, 89.7% in the left bundle arm, and the relative risk was 0.95. However, the 95% confidence interval was 0.88 to 1.02, and this did not meet the non-inferiority margin because the Spanish authors had a non-inferiority margin was set at 10%, and a lower bound of the 95% confidence interval was less than that at 0.8. So I say kudos to the Spanish investigators for setting a fair and proper non-inferiority margin. Jackie P. has published the 5-year follow-up of the HIS Alternative 1 trial from Denmark. This included only 50 patients with HFrEF and left bundle branch block who were randomized a long time ago to HIS bundle pacing or biv pacing. Now, 19 patients ultimately received the HIS CRT versus 31 with biv pacing because of course procedural crossover. The median follow-up here was 5 years, and there were more lead revisions. 37% versus 3%, more generator replacements, 47% versus 10% in the HIS CRT group compared with the biv CRT group. The authors state that all-cause mortality or hospitalizations for heart failure were similar between the groups, but the hazard ratio was 0.32 or 68% lower in the HIS CRT arm, but the 95% confidence intervals went from 0.07 to 1.49. The echocardiographic response was comparable between the two groups. So again, very small numbers of patients, very wide confidence intervals, but when you can get HIS capture, it looks like the rates are fairly similar. And then, of course, the third trial at a European Heart Rhythm, the French LeCart, LECART trial, which is an abstract form but not published, enrolled 168 patients with HFrEF wide QRS, and they used stylet-driven leads for left bundle pacing versus biv pacing. And they found the primary endpoint, which was a composite of death, heart failure, device-related complications requiring surgery, or failure to deliver CRT at 1 year, was 25% in the BIV group and 12% in the left bundle area group. That's a hazard ratio of 2.1. The driver of the composite was complications leading to reinterventions. It was 15% with BIV pacing and only 2% with left bundle pacing. So otherwise, results were similar, including secondary endpoints of New York Heart Association functional class, 6-minute walk, quality of life, left ventricular ejection fraction, and BNP. So my comments, you probably noticed the trends in these studies. They were mostly short follow-up, small numbers of patients, which then require mixing hard endpoints like death and hospitalization with such things as device revisions or clinical composite scores. What we need, and we'll have to wait for a while, are large, hard outcome trials, such as left versus left. The signals from these smaller studies are encouraging, but I don't think they get us to the point of favoring CSP over BIV pacing. Remember, BIV pacing was established in multiple large randomized trials. In my mind, it should be the preferred first technique. At our center, when we have a CRT-eligible patient, we try to randomize in the left versus left trial. Now, one huge question that comes up with CRT pacing, at least, not so much defibrillators, but CRT-P, is what happens when you place the first RV lead into a superb left bundle branch area spot. Now, that's the RV lead, but you see perfect capture of the left bundle and narrowing of the QRS. My question, and I don't know the answer, is do I stop there, or do you go ahead and place the CS lead to achieve BIV pacing? I don't know the answer. Now, you can't do this, of course, with CRT-D because the RV defibrillator lead goes into the RV apex, and then you're either going to need a CS lead or a left bundle branch area lead. Now, outside of the left versus left trial, I favor doing the CS lead first because this is the most best established. However, left bundle branch pacing can serve as a backup. And if you don't do it during normal pacing, then you won't have the skills to do it as a backup when CS veins are not adequate. Now, one meta note on this topic. We have been doing CSP since 2016, and what would have been a preferred strategy is a large outcome trial commencing at the beginning of the story back in 2016. If that were done, we would be on our way to knowing how this system compares to BIV pacing. Instead, we get these small, limited trials, and we await large outcome trials. Now, you know why this has occurred? Because industry has had no interest in funding CSP studies, because if these were positive, it would decrease the sales of more profitable BIV generators. None of this is nefarious. It's just the downside of being so dependent on industry funding. In many cases, there's a confluence of interest between industry and patient care. For instance, industry will fund trials of new devices, and if these new devices improve patient care, that's great. But in the case of conduction system pacing, industry had no interest in funding trials that could potentially decrease the number of profitable BIV pacers. This would require government funding and public funding. I'm glad that this is going on now, but I wished it was going on earlier. All right, final topic today is a new EP training document has been published. Numerous authors have written an update to the 2015 guidance on what constitutes a competent EP doctor coming out of fellowship. Now, you would not think something like this would make the podcast because it is not a study or a trial, but I cover it because it contains the downstream effect of company marketing combined with inadequate critical appraisal skills, along with one of medicine's longest traditions, and that is the entrenchment of therapeutic fashion. What we do becomes fashionable. Now, the main figure of the document contains the list of procedures required for level 1 competency, and there are a lot of normal things there, like pacing, and EP studies, and ablation, etc. But the second from the last is that EP fellows must do 25 left atrial appendage occlusions. This I see as a problem because there is no compelling evidence for doing this procedure, which I've said about 1 million times, but it's worth going through again. Think about it. There's 5 trials now. Protect. This did not pass FDA muster. Prevail missed its non-inferiority endpoint against warfarin. Prague 17 was inconclusive due to too few events. Closure-AF, which just came out and showed that left atrial appendage closure is clearly inferior to best medical therapy, and Champion-AF, which was positive on paper but clearly negative for Watchman due to increased stroke rates and no difference in major bleeding. Now, why would EP leaders think that requiring left atrial appendage closure should be a core skill? You might say, John, what about patients who cannot take oral anticoagulation? We would want EP doctors to put in appendage closure devices for these patients. But my answer to that would be that there is no data to support use in these patients. Do you know that none of these patients have been randomized? We just assume from the dubious data that I just cited that for some reason, Watchman would be better than nothing in patients who cannot take oral anticoagulation. But I don't know that that's true, and we don't have any data. Okay, that this LA appendage closure procedure is now endorsed in guidelines, and it's now included in competency statements, shows you how industry interests slowly and gradually infiltrate medical practice. Now, industry supports the professional societies, and it supports key opinion leaders. Here at HRS and really all major cardiology meetings, the influence of industry is on display both directly, you can see it in the largesse of the expos, and it's indirectly through sponsorship of the society. Therefore, key opinion leaders, many of whom have done these clinical trials and accepted the biased endpoints, now support the procedure from the podium, but also they codify it into guidance documents such as this core competency guidance statement. Gradually, this therapeutic fashion becomes established, left atrial appendage closure becomes normalized, despite the lack of strong evidence for it. Fellows in training spend time and talent on learning how to measure the appendage and how to insert this device. They either forget or they never knew the PREVAIL trial required by FDA failed to meet non-inferiority, despite a 1.75 non-inferiority margin. Why did this happen? Why did Watchman not make non-inferiority in PREVAIL? It didn't make non-inferiority because of higher stroke rates in the Watchman arm, which is exactly what was seen 15 years later in a Champion-AF trial with the Watchman Flex device. Now, this document mysteriously requires 210 EP studies and 145 CIED procedures, but it requires exactly 0 formal trial appraisals. There is nothing in this document on how not to be bamboozled by bias in the medical literature. There's nothing on how understanding how non-inferiority can be used to bias studies in favor of new and expensive devices. I consider trial appraisal and evidence appraisal very similar to a procedure. You have to learn the basics of how to do it, and then you have to practice it, just like a procedure. Sadly, this is not included in the competency document, but I wished it were. So that's it for this week in cardiology, and I want to say thank you to all of those who came up to me at the European Heart Rhythm meeting and HRS to say they listened to the podcast. Your words mean a lot to me, and I thank you very much for that. So until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.